Hello, and thank you for joining us for the Pharmacy Cannabis Lecture Series. Each episode is designed to deliver a small dose of cannabis education. I'm Candace Haas, and I want to thank all of our viewers for being with us today, as well as our customers from the Pottery and from the Pharmacy Santa Ana, Santa Barbara, and Berkeley for joining us today. Today, we're going to be talking about epilepsy and cannabis. As we know, or as you may have learned in the past from our webinar series, the off-label use of cannabis in treating seizures has been known since ancient times. And as we know anecdotally, many people living with uncontrolled seizures have reported beneficial effects and reduced seizure activity when using medical cannabis, especially those strains rich in CBD. And then just recently, after many years of patient testimonials, clinical trials, and research, in 2019, the U.S. Food and Drug Administration approved Epidiolex, a cannabidiol CBD oral solution for the treatment of certain types of seizures. We welcome two great guest speakers for this special presentation on epilepsy and cannabis. The first speaker is Dr. David Bearman M.D., who has treated many epilepsy patients in his 40 years of medical practice. And joining him is William Britt, who's been living with epilepsy and using cannabis to control his seizures for more than 45 years. Our first speaker, as I said, is Dr. David Bearman, M.D. I first met Dr. Bearman many days ago in the early days of medical cannabis, where there is very few doctors who risk their licenses to provide cannabis recommendations to patients in need. He was one of the first in their state and is still one of the great doctors practicing cannabinoid medicine. Dr. Bearman is now retired, but had a long, successful medical career. In his 40 years practicing medicine, he worked in public health, administrative medicine, primary care, pain management, and cannabinology. He currently serves as the vice president of the American Academy of Cannabinoid Medicine. He's also the author of several books on the history and medical use of cannabis, Medicine, A Guide to Practical Cannabinoid Medicine, and Drugs Are Not the Devil's Tool. Dr. Bearman is also featured in the documentary Medical Cannabis and Its Impact on Human Health. Our second guest speaker is William Britt. Bill is the founder and director of the Association of Patient Advocates. In 2002, Bill was arrested in Washington, D.C. for blocking the entrance to the Health and Human Services building with other patients, calling for the rescheduling of cannabis. And then later in 2002, he filed a lawsuit with the federal government to reschedule cannabis, which was unfortunately denied. He was also part of a lawsuit in California that forced San Diego County to recognize and provide medical marijuana cards issued by the county government. Since 2007, Bill has been on the approved panel of experts for LA Superior Court. He's testified as a cannabis expert regarding cultivation, manufacturing, distribution, patterns of use, and child endangerment, and has testified as an expert in every county in Southern California in over 300 cases. He's also a medical cannabis patient himself, living with post-polio syndrome and epilepsy most of his life. He found out early on that cannabis provides much better relief for his symptoms than prescription drugs ever did. We'll begin with some information from Dr. Bearman with some information on the endocannabinoid system, on retrograde inhibition, how cannabis works to decrease the frequency of epileptic episodes, and the side effects of cannabis. So thank you so much for being with us today, Dr. Bearman.
It's a pleasure to be here, and you do a great job with these things. And I've been around Bill at a number of events, and I'm very impressed by the way that he has educated himself and the fact that he's so effective as an expert witness. I must say that I'm also an expert witness, and I've testified about 500 times in court. And what's interesting is how little people know about the endocannabinoid system, which is the largest neurotransmitter system in the human body. And their doctors have been pushing, the doctors that I know, to get medical schools to teach more about this. And if there are any physicians, nurses, other healthcare providers who are interested in that, I would hope that you would, go ahead and try to get your professor to take a look at this book, or to take a look at the other book called Drugs Are Not the Devil's Tools, which is a great history book. I actually like history and wrote it to try to encourage college students and high school students to look into history, because the world didn't just begin with your birth. I know you might think that, but that's not the case. Okay, so let's take a look at the next. This is Voltaire, who was a little bit skeptical of what doctors could do. And I think part of the problem that we have in modern times is that doctors look at therapeutic treatments or therapeutic substances mainly as a product of the pharmacy people. And if you recognize that synthetic or semi-synthetic drugs were first invented in 1897. So what did we do before that? Before that, we relied on plant-based medicine, and cannabis was certainly one of the plant-based medicines that we relied on. As a matter of fact, in the turn of the 19th to 20th century, cannabis was the third most common ingredient in prescription medication and over-the-counter medication after alcohol and opium. Yep. So we're talking about epilepsy today. And, we need to know a little bit about the endocannabinoid system, and I'm going to talk about that in a minute as to how that is related to the treatment of epilepsy. So epilepsy is excessive neuronal firing in a portion of the brain. Could be any portion of the brain. And it causes muscle contractions, uncontrolled shaking, a lot of other symptoms, and possibly Bill Britt will go into them. And it usually occurs around scar tissue in the brain. Scar tissue could come from a traumatic birth. It could come from injury. Could come from having an abnormal collection of blood vessels. So your epilepsy can be genetic. It can be from a traumatic brain injury. It can be from a space occupying mass. And it is usually the focal point for the origin of the seizures that people have. And the reason that I think epilepsy is somewhat difficult to treat is because not only are there so many things that can cause it, but they all are not the same in terms of the neurons that are affected. And so not all medication for epilepsy works on everybody, and some people who have epilepsy get very little relief. And then some of the medications that are out there, the list is very long, but these are some that you may be familiar with in the audience and may yourself take. And what they do is a similar thing to what the cannabinoids do, and that is they slow down the speed of neurotransmission. And that's what you want to do to decrease the onset of an epileptic seizure. And before I go, there's different kinds of the nomenclature. You have petit mal seizures, which can just be a momentary lapse of consciousness. You can have grand mal seizures. You can have something called Jacksonian seizures, which may be set off, say, by a visual trigger. Going by a bunch of telephone poles at too fast a rate may trigger epilepsy in some people. So, okay, that was the epilepsy. Now, the endocannabinoid system, that's what ECS stands for, is made up of a number of parts, a number of constituents. The two naturally occurring or occurring within the human brain cannabinoid or endocannabinoids, that is, cannabinoids that are found within the brain, are 2-AG and anandamide. There are different receptors. CB1 and CB2 are the most common, but there are several other receptors that are also affected. The CB1 receptors are found largely in the brain. The CB2 receptors are found largely in the periphery. There are a couple of enzymes, fatty acid anhydrase, which is what FA stands for. And to say the truth, I forgot what MyGel stands for. But anyway, those are the enzymes that help the body metabolize the cannabinoids, both the endocannabinoids and the phyto meaning plant, phytocannabinoids. This is important because the cannabinoids don't stick around, or certainly the endocannabinoids, for very long. Other elements that are important as far as the endocannabinoid system is dopamine, and that last thing should say dopamine transporter rather than dopamine transmitter. We'll get into that in a minute. So while epilepsy itself is not an endocannabinoid deficiency, cannabis has been found to be very helpful in terms of treating a vast number of conditions. We'll talk about them for a second, because the mechanism of action for treating things like post-traumatic stress disorder, attention deficit disorder, migraines, is very similar or identical to the mechanism of action in terms of dealing with epilepsy. So these are some of the conditions that can be caused by what Dr. Ethan Russo and Dr. at UC Irvine, Daniel Piamelli, have deemed the endocannabinoid system deficiency. And the attention deficit disorder, depression, anxiety are all conditions which can benefit from cannabis, and which may be related to or associated with the so-called endocannabinoid deficiency, meaning they don't have as much anandamide or 2-AG as the average person. So in talking about post-traumatic stress disorder, it is very helpful because it affects the midbrain, and the midbrain is responsible for fight or flight. So if a person has post-traumatic stress disorder, they can get very angry. People with road rage probably have PTSD, and it helps people sleep, gets rid of the nightmares of PTSD, and it allows people to deal with other people without being angry or abrupt. And so in terms of your epilepsy, it tends to slow down the speed of neurotransmission, which means you're less likely to have this uncontrolled, excessive neural stimulation, and you may not have epilepsy, or you will have fewer epileptic seizures. Cannabis also works for attention deficit disorder, which is also an endocannabinoid deficiency syndrome, and it helps people focus. And most of the people that I've seen that started using cannabis in their early teens found that their grades went from D's and F's to A's and D's as a result of their ability to focus on their homework and the lectures, and just generally be less scattered and more focused.
Yep.
So dopamine is important, and that's another neurotransmitter, and it's one that we know even less about than the endocannabinoids. And you can see from what was said here that we don't really understand fully the effects of dopamine, because sometimes it makes things go faster, sometimes it makes things go slower. And we'll see how dopamine is involved in terms of cannabis working to decrease the frequency of epileptic seizures. So dopamine, one of the things about the dopamine is that the PTSD can cause an increase in the dopamine, the thing that attaches to it. And by attaching to the dopamine molecule, you decrease the amount of dopamine and you increase the speed of neurotransmission. And of course, we're talking about epilepsy. Increased speed of neurotransmission is what is the basis for epileptic seizures. So this is the presynaptic neuron and the postsynaptic neuron. And you can see that if the postsynaptic neuron sends back as a result of the cannabinoids, messages to the presynaptic neuron, and that causes a release of dopamine. And the dopamine causes depolarization of the presynaptic neuron. Now, what does all this gobbledygook mean? What it means is that it's harder to stimulate the presynaptic neuron once you have the endocannabinoid functioning, or you have cannabis, because you now have the presynaptic neuron, by being depolarized, makes it much more difficult for the next neural impulse coming along to stimulate that neuron.
Cool.
And here again, you have a picture that shows what's called retrograde inhibition. And what that means is that the postsynaptic neuron sends back anandamide to the presynaptic neuron, which causes the release of dopamine, which causes depolarization of the presynaptic neuron. And this shows that somebody that has more dopamine transporter, and so the dopamine transporter ties up the dopamine, and you increase the amount of dopamine transporter if you have post-traumatic stress disorder, and if you run into a situation that's similar or stressful to the trauma that caused the problem in the first place, the post-traumatic stress disorder, you have less dopamine available. And so you're going to have more rapidly moving, in this case, a neurotransmission from the limbic system, and less opportunity for the cerebral cortex, the more rational part of the brain, to act. So dopamine depolarizes the presynaptic neuron, and it makes it harder to stimulate the presynaptic neuron. This is important not only in terms of epilepsy, but also in terms of PTSD and in terms of attention deficit disorder. Okay, so the endocannabinoid system is involved in synaptic inhibition. It's involved in synaptic inhibition, not just for attention deficit disorder, not just for PTSD, but also for epilepsy. This just shows you that some of the cannabinoids and some of their therapeutic effects. The cannabis, like all plants, is complicated. There are over 513 molecules in cannabis. About 130 or 140 of them are cannabinoids, and over 200 of them are terpenes. Terpenes are what give the plant its unique odor, but many terpenes have therapeutic value themselves. And there's a number of terpenes, as we'll see, that are useful in decreasing anxiety, and at least one that's found in lavender that may be useful in decreasing the frequency of epilepsy. So the endogenous and exogenous cannabinoids increase the availability of dopamine. And this addresses the problem of too little dopamine, which may be part of the endocannabinoid deficiency syndrome, or having too much dopamine transporter, which can come about if you have post-traumatic stress disorder. So there's a combination of ingredients in the cannabis that are helpful in terms of calming people down. These include THC, and as we heard from our hostess, CBD, and also terpenes. Linalool has been specifically mentioned as one of the terpenes that can decrease the likelihood of seizure disorder. Now, I mentioned Ramsey and Davis in their 1947 study. They're the first people that showed that cannabis is useful in treating epilepsy. And in fact, they said in their 1949 article that was published that it might be a good idea to do some research in the future. And there was about 60 years in the future after they did this study. Now, the interesting thing about this is that they did not use CBD. They used synthetic THC. They had 7 subjects who were institutionalized. They're children or young adults who had cerebral palsy, and they had also intractable seizures. And with their synthetic THC, 5 of the 7 people ended up having 90% fewer or no epileptic seizures. And to me, this demonstrates that the THC is an important constituent as far as decreasing the frequency of epilepsy. Charlotte's Web, or Epidiolex, which came out of the fact that Charlotte's Web had a high CBD, only decreases the frequency of epilepsy by 30%. So you can see that having some THC involved is probably a good idea. Now, obviously, everybody's different. We've already talked about the different causes of epilepsy. So for some people, CBD alone or CBD with linalool might do the job completely. But if it doesn't, then adding THC is not a problem, and relatively low doses of THC can be beneficial in terms of treating epilepsy. So there's a lot of terpenes that are anti-anxiety. Linalool, of course, is one of them. And while anxiety is an epilepsy, it certainly wouldn't hurt you to eat a mango a day that has myrcene in it. Have some lemon juice, lime juice that has limonene, and pepper has caryophyllene in it. And actually, the caryophyllene acts a lot like CBD. So if you find that the CBD is helpful, you may find that caryophyllene makes the CBD even more helpful. So plants have something called the Entourage Effect. And this is the sum of all of the therapeutic constituents of the plant acting together or in combination with each other. And as we mentioned, cannabis has several cannabinoids, terpenes, and flavonoids that can act together to have a more beneficial effect than just one constituent acting alone. Now, obviously, there's a certain amount of trial and error. I mean, part of the problem in the United States, not that we don't have lots of problems, but is that cannabis is a Schedule I drug. What that means is a Schedule I drug allegedly has no known medical use in the United States and has a high propensity for problems and for being abused. I don't think that either of those things are true about cannabis. And of course, there are somewhat over 35 states, maybe now it's more like 45 states, in which cannabis is legal to be recommended by a physician as a medicine. So there should be an effort to reschedule cannabis. And some people have even said it should be descheduled. The schedule goes from 1 to 5. Epidiolex, which is CBD, is either 5 or has recently been descheduled. And we ought to pressure them to have THC rescheduled or descheduled. And since Bill was involved in going to Washington, D.C., he probably knows more about the practical aspects of this. And by the way, in terms of rescheduling cannabis, in 1988, 16 years after NORML asked to have it rescheduled, the DEA's chief administrative law judge, one Francis Young, said cannabis should be rescheduled to Schedule II, which means that doctors could have prescribed it since 1988. He was overruled by George H.W. Bush's head of the DEA, John Lawn. In his finding of fact, Judge Francis Young said that cannabis was one of the safest therapeutic agents known to man, and that it was safer than eating 10 potatoes. So we don't eat those French fries at McDonald's. Okay, so the dose of CBD, THC, and terpene all affect the outcome. In some instances, less is better than more. A cannabinoid medicine specialist should supervise the dosage for epilepsy. Dr. Bonnie Goldstein, who has recently written a book, is considered the top cannabinoid medicine epilepsy specialist. She practices out of Los Angeles and has an extremely good reputation. In fact, Dr. Goldstein and I were involved as expert witnesses in a case involving autism. And I got a chance to read her deposition. And as I told the attorney and told Dr. Goldstein, it was over the moon, off the wall, very good. So, we're talking about cannabinoids here, and the endocannabinoids are those that are found within the body, and the phytocannabinoids are the plant-based cannabinoids. So, how does cannabis work to decrease the frequency of seizures? It increases the synaptic level of dopamine, and this enhances the retrograde inhibition, which means that it slows down the speed of neurotransmission. It decreases the internal and external neural input. It also has the antidepressant effect, which certainly doesn't hurt. It has a general calming effect. And as I've been saying over and over again, it decreases the speed of neurotransmission. Be nice if I spelled it correctly. Forget about that last I. Oh, and so we talked about the CB1 receptors being largely in the brain. As you can see by the blue, that's where many of the CB1 receptors are. And the CB2 receptors are largely in the periphery. The CB2 receptors have something to do with downregulating the immune system, which is why cannabis works for many autoimmune diseases. That's another lecture. This just tells you that the CB1 receptors are located throughout the brain, and this is where part of the brain is that they're located. Now, you can see that the substantia nigra and globus pallidus coordinate movements. So if you can slow down the speed of neurotransmission in that part of the brain, then you may have some benefit in terms of decreasing the frequency of epilepsy. So it may work in decreasing epileptic seizures. Again, this is just a repeat of what I've already said. Causes release of dopamine, triggers retrograde inhibition, slows the speed of neurotransmission. And when you're looking at post-traumatic stress disorder, it allows the cerebral cortex to more rationally assess fear due to fewer thoughts being transmitted to the cortex from the limbic system. So it decreases emotional excitability, and it decreases the excitability of the neurons, and it's increased neuronal excitability that leads to the epileptic seizures. So this was just from the MAPS people, and it has to do with PTSD, which is an endocannabinoid deficiency syndrome. But the reason I throw PTSD and ADD in here is to show you that cannabis has multiple uses, and that decreasing the speed of neurotransmission is not only beneficial for epilepsy, but for a number of other medical conditions, some of which may trigger epileptic seizures. Because the more excitability you have of the neurons, the easier it is to have a seizure. And here's Judge Young. I forgot I had this slide in there in which he says it's safer than many foods. It's one of the safest therapeutic agents known to man. And as I say, his recommendation to reschedule it to Schedule 2 was overruled. Just for your historic information, Dr. William Woodward, who was a physician, lawyer, the chief lobbyist for the AMA, had been the commissioner of health for Washington, D.C., and the health commissioner for Boston, and had been president of the American Public Health Association. In his testimony before the House Ways and Means Committee, he said in 1937, the AMA knows of no dangers from the use of cannabis, from the medical use of cannabis. Now, in the 1920s, American physicians wrote 3 million prescriptions a year that contained cannabis, and there were over 25 over-the-counter medications that contained cannabis. And it's with that knowledge that Dr. Woodward was able to say that the AMA knows of no dangers from the medical use of cannabis. So, conclusion. Cannabis can be efficacious in the treatment of epilepsy, and Mr. Britt, I think, will tell you how efficacious it's been for him. And we need to do more research. If it's ever descheduled from Schedule 1, I think we'll see a lot more research in this country. Now, we actually are seeing research being done in England, research being done in Italy, research being done in Israel, research being done in Australia and New Zealand. So even if we never get smart enough to deschedule cannabis and make it either Schedule 5 like Epidiolex or possibly Schedule 3 like Marinol, which is THC.
Yep.
We're going to see more research not only in regards to epilepsy, but also other conditions which are affected by endocannabinoid system deficiency. And the more that we learn about the endocannabinoid system, and the more that we learn about how cannabis affects these other conditions which benefit from having an increased amount of dopamine and a decreased speed of neurotransmission, the more that we're going to see understanding of epilepsy and cannabis's use in treating epilepsy. And we're probably going to see some synthetic cannabinoids or selective anandamide reuptake inhibitors. So our own endocannabinoids, we will have more of them. And so you can reach me at David Bearman at cox.net. I think my website is in disrepair, but so if you want to get a hold of me, you can get a hold of me at David Bearman at cox.net. And I think that is, oh, I know, I end up with a slide. I have mentioned Dr. Mechoulam. Dr. Mechoulam in 1964 isolated and characterized the chemical structure, the molecular structure of THC. And he has been doing research ever since. Unfortunately, because of the COVID, I wasn't able to go to Israel for the celebration of Dr. Mechoulam's 90th birthday. I was able to go to Jerusalem for the celebration of his 80th birthday. And he had, I have to tell you this story. He and one of his colleagues decided that they should take a look at cannabis and what the ingredient in there was that caused people to have euphoria. All other synthetic drugs, or excuse me, all other recreational or adult drugs had been so studied so that we knew what cocaine looked like, what molecular structure looked like, but we didn't know what THC looked like. So Mechoulam said that he was friends with the deputy chief of police of Jerusalem, and he called him up and said, look, we want to do some study here on cannabis. Do you have any? Can you give us any? And he said, are you guys reliable? Yeah, we're reliable out here at the Hebrew University. And he said, okay, come on down. So he went to the police station in Jerusalem, and the deputy chief gave him a shopping bag with 5 kilos of cannabis in it. And he got on a bus and went back to and the rest is history. So I thank you very much. I hope that I've given Bill Britt an adequate introduction here, because Bill will tell you what this all means. And so if you have any questions, we'll go over them at the end of Bill's presentation. And I thank you very much for your attention.
Yeah, thank you, Dr. Bearman. That was wonderful. That was great information. And you really helped explain like what's going on in the brain when people are using cannabis and how that helps stop epilepsy. And I love how you tied in ADHD, PTSD as well, because it all kind of works the same way. So thanks for making that really easy for people to understand. That was great. So now I thought it'd be good to bring in Bill, who is one of my good friends. And he's actually was like my mentor when I first got into the cannabis industry or cannabis community back then. And I know that he's been living with epilepsy and post-polio his whole life, and that he's been using cannabis instead of pharmaceutical medications, or probably with in conjunction at times, right? Right. Yeah. So go ahead, Bill, if you could tell us a little bit about like what treatments you tried, what type of seizures you had, and then kind of how you discovered cannabis as a better way to treat those.
First, I'd like to talk a little bit about my personal experience with epilepsy, having epilepsy, a person with epilepsy. People always say you're an epileptic, you're a disabled person. We're a person with a disability. We are a person first. Our disability does not define us. But I discovered epilepsy at a young age in grade school. I remember I was like in 5th or 6th grade, and a kid named Kevin had a seizure. He had the kind of seizures where you wander around and you stare into space, and the truth is we ended up making fun of this kid, and I ended up befriending him later on. But and people made fun of him throughout his life. I knew him through high school, and it's like his life was so impacted because the ignorance and the fear, and that we don't, and the how nasty kids can be. We all know how nasty kids can be, but but then something happened then, and then in high school, I was sitting in class one day, and I woke up in the hospital.
Wow.
And they're asking you, where, what's your name? Oh, I knew my name. What day is it? And I said, it's Thursday. And they said, what day is it? It's Thursday. And about an hour, it took me about an hour to say, oh no, it's Tuesday. It's not Thursday, because I had, disorientation, and I'll talk a little bit about that. But the seizures there are 3 basic types. They say that there's 3 basic types of seizures, and it's determined by whether it takes over half of your brain or if it takes over all your brain. And there's the first thing that happens is what they call an aura, and it was like a feeling of you get this deja vu feeling, and the type of seizures that they're saying this. There's I'm sorry.
I think Dr. Bearman mentioned in his presentation too, right?
The nomenclature is a little bit confusing because it's changed. The nomenclature that I gave you is old-fashioned, and I think that Bill here may give you the contemporary thing that I mentioned: petit mal, grand mal, Jacksonian, and I believe that the nomenclature has changed to something different now. Is that correct? And
that goes to speak with the knowledge of epilepsy right now. It's been around for thousands of years, and we've known about it. But there's so much more that needs to be known. So the latest is there's 3 basic types they call focal, general, and unknown. Focal start in one side of your brain and generally stay in that side of your brain, and that's why. I believe that people can still function, or like they look like they're functioning, but they might be staring off into space and like trip. Yeah. And like children, there's children that have like 100 seizure in a day, 100 of these little seizures. It can last as long as several minutes, or a couple.
If I can interrupt for a second, Bill, and I'll try not to, but that's what we used to call petit mal seizures, but they've gotten a little bit more sophisticated, and as you pointed out, they need to get a lot more sophisticated.
The other kind is general, where it takes over both sides, and that's generally, well, they called mine grand mal, but I'm believing that it's a general seizure because I had the first part where what happens is at the beginning it's like you're feeling a little confused, and now you're looking, and then all of a sudden it's like I'm there and people are talking to me, but I'm not there. I can't move. I can't respond. And then you go out, and actually I've had auras. Well, it starts with an aura, this feeling, and why this is why I think that that first one really wasn't my first one, because you can have seizures while you're sleeping. That's the third type, is unknown, because the unknown ones usually happen when you're sleeping or when you're not paying attention, or you don't even realize that it happens. So all of a sudden, I get this feeling, and it doesn't always progress onto a seizure. So it doesn't know, and it's a scary feeling. And some people will try to, put something in their mouth but it's not always good to put something in your mouth because you can damage, or your teeth. So you get this feeling, you're disconnected, you're out of control, and then with me, it was unconsciousness. And during this unconsciousness, your body is shaking. It's a scary thing. I've actually seen somebody. If you've seen somebody have a seizure, you stop breathing for a while. You stop breathing. Your face turns purple. You go between shaking, and it's called tonic, clonic, atonic, tonic, where you're either all limp, and then you're totally rigid. Like say if you try, the problem is if you try to help somebody, the best thing is to like try to roll them over on their side, but don't ever try to grab them, or because they can. It's like this. You have almost super strength, because you could, like, if they lash out and you're right there, you could get hit. You could get hurt, or you could hurt them. And one of the worst things is if you're standing up, because I've had seizures when I was in a shower. I've never really badly hit my head, but you can hit your head. Mm-hmm. I had a seizure while I was driving a car, and that was somebody saved my life basically. He was driving along. I was driving along the freeway, and somebody looked over, and there's a car with no driver. So he took his car and pushed me over into the ice plant on the side. So it's very important that at that time I was taking Dilantin, and which is a medication that has some side effects that I didn't really like, especially if you take it to the level that the doctors want you to. And I was also drinking alcohol. And I think one of the worst seizures I ever had was we went on a bender for like a week. We went up to Sacramento on a cruise, a Delta cruise, and we drank. And on the last day I said, I'm just going to stop right here, which was the worst thing you can do. If you're going to drink, but stopping abruptly, I had the worst seizure. I had like multiple seizures, and it was just, that's when I said, okay, that's it for alcohol, and I had access to cannabis, but I never really had consistent quality. I could never afford, the good quality. I never could have. And the whole thing about, the reason you take it like the Dilantin is it's a medicine. You can take it consistently every day, every hour, if that works. So that's why it's so important. And before Prop 215, it was almost impossible to have that. And what happened with Prop 215 is I found something happened with these, you had compassionate growers and people who actually cared. And I was able to get, and for the first time wake and bake the first thing in the morning, every day. I started, I had my good quality cannabis, or, I had edibles. I had, because the edibles, it's good for the nighttime. So you're not, it carries on, because when the levels go down at night. But having access to all the different kinds, it just really made it, it's been, since 96, I've been seizure free. I haven't had one seizure in 25 years using only cannabis. I stopped taking all other drugs. So
I mean, seizures are very, very serious. I know I had a friend, unfortunately, that passed away from having a seizure in a bathtub. So definitely, talk with your doctor if you are coming off any kind of other medications. Definitely do under a doctor's advice. But there's many patients that have similar stories to you.
My doctor was, when I went to the clinic doctor at the time, before they were not, they were just. He didn't want anything to do with it. Most doctors don't want anything to do with it.
If I can talk about doctors for a minute and plug my book, is the reason that doctors are partially averse to cannabis is most of them have never heard of the endocannabinoid system, the largest neurotransmitter system in the human body. And if you want your doctor to understand cannabis, this book, which is about 160 pages long, goes into some of the stuff in a little bit more detail than what I talked about, so they understand it's not magic. It's not a bunch of old hippies saying, well, this is a good idea so we can get stoned. No, this is a good idea so that we can treat these kinds of conditions. I remember one of my patients who had epilepsy, and he went out east for a week, and he couldn't get any cannabis in New Jersey, and he had a seizure every day. So, I mean, what Bill Britt's experience is somewhat atypical in that it's been so successful for so long, but it's not particularly atypical. There are many people with epilepsy have found, particularly if they find the right combination of THC, CBD, and linalool, whatever, have dramatically decreased their frequency of seizures. And it's not that uncommon to have the kind of success that Bill Britt is talking about.
The two major causes of seizures are lack of sleep and emotional stress or anxiety and stress.
Mm-hmm.
So what is life? Life is so stressful. I mean, and insomnia is one of the biggest problems that we have today. And what are the two biggest things that cannabis can help with?
Yeah.
It helps you with sleep and anxiety if you take the right dosage. That can be the problem. My mother just turned 85 years old and she has sleep problems, but there's a fine threshold between the levels, like she's using about 5 to 10 milligrams of THC, or less, and any more than that will causes major anxiety, in which it makes her reluctant to use the medicine. Some people are so sensitive to that. That's why it's so nice now that we have the CBD, which can counteract a lot of those effects. But it's still expensive, and it's still like right now. Epidiolex. Dr. Bearman talked about Epidiolex. That's for a seizure medic. That's an isolated. That's what's called an isolate. So it means the chemical is isolated. So there's only one chemical, CBD, in there. People are, the dosage for that is 800 to 1200 milligrams a day. At a cost of $32,000 a year. And as Dr. Bearman said, there's it's only 30% effective, but if only they would have added some, there's a thing called whole plant extract or full spectrum. And full spectrum is, as Dr. Bearman was saying, was adds in the terpenes and minor cannabinoids like CBG, CBN, there's other chemicals that are involved that are entourage. They call the entourage effects.
Yep. So speaking of like what you do for yourself and like products that you've used or doses, so like what's your daily regimen like that to help keep the seizures at bay?
I used to be flower. I used to really be flower and wax centric, but as I've been smoking for over 50 years.
Mm-hmm.
And my lungs aren't what they used to be. So I'm trying to transition. And that's the problem too, because there are good quality, the better quality. It's hard to even afford the better quality, but there are pills. I like the tinctures and drops. My mom's been using the CBD and THC drops. That way you can really titrate, you can really control exactly how much you get it. Because it's all about consistency. With me, I have a really high tolerance, so I use any and all I can get.
Mm-hmm.
And it's been, like I say, it's been difficult. Actually, until recently, when I was able to get on a compassion program. Thanks to the pharmacy. But and I'm so glad that these programs are going to be starting now, because patients, when legalization came, it really hurt a lot of patients, because there was a lot of, there weren't incentives for the entrepreneurs and big companies and it was illegal to actually give away too.
Until SB 34, we actually weren't allowed to, but now with SB 34, they give a 5-year period when we can give away free medicine to patients, and we're 2 years in, so we have 3 years on that program before we have to get it renewed again.
Well, I applaud that.
Yeah. So let's see. So like, have you found that THC works best for you? CBD works best for you? You said like you tried CBG as well. Did you find like which one of those do you prefer? And
I prefer THC, but I've been trying to get more CBD as it gets cheaper and more readily available.
Mm-hmm.
But I like the vape pens are great. I'm really a fan of hash, but it's hard to find really, really good bubble hash. The milky hash is my absolute favorite. But right now the vape pens, and it's difficult because most of the vape pens make you choke and cough. If you find, and that's why there really is a big difference between the street market on the street and buying from a dispensary, like the pharmacy. It really is important to know that if you're a medical, that it's been tested. Again, if you want linalool, that the linalool is in there. I don't know if I'm buying off the street. You don't know what the heck's in it or what dosage is in. And when it's so important, again, that I know exactly that if I know that if I'm taking about 50 to 100 milligrams a day, and that works for me, that's what I'm going to get, that I'm going to have a consistent, dosage instead of taking too much or too little. Because if you take too much, it builds your tolerance too high, and then it's more expensive. And you want to, if you take too low, then it's not as effective.
Yeah,
Let's
so
talk a little bit about THC and CBD. Now, CBD partially fits into the CB1 receptor. THC fully fits into the CB1 receptor. So it makes sense that CBD has some beneficial effect as far as epilepsy is concerned, but THC is more the equivalent of anandamide, that is the endocannabinoid that exists within us, than CBD. And the anandamide tends to slow down the speed of neurotransmission better than CBD. CBD is more effective in terms of downregulating the immune system. Not that it doesn't work on some people with epilepsy. And as I mentioned at one of my first slides, there's a lot of different causes of epilepsy. So there's no one size fits all. And if Epidiolex or if just CBD itself works for you, you're fortunate. But the whole plant, as Bill pointed out, is going to have a lot more constituents in it. And as I mentioned, it's going to work by the entourage effect. And I think Billy mentioned that as well.
Yeah, I think what I've seen too is in terms of patients coming into the dispensary is people using tinctures, because if you're going to be using cannabis every day, you know, at least a couple times a day, you're going to want something that's consistent. Like you said, you can control your dose, move it up or down. And then also something that doesn't have like a lot of sugars, you know, it doesn't like you're not inhaling it in your lungs. So it's something that's better for you if you're using it often for long periods of time. Plus, a lot of times with tinctures, there's a better like per milligram cost as well.
Right.
And then you can also make tinctures and stuff like that at home as well. So under California law, every patient can grow 6 plants per patient per house. If you're just an adult use consumer, it's 6 plants per house. But if you're a patient, it's every patient gets 6 plants. So you can make your own tinctures, you know, so there's other ways to make it more affordable.
Does the pharmacy have higher THC levels for medical? Do they have any medical? Do they allow like a? Yeah,
California law allows people with cannabis recommendations from a licensed doctor to buy higher amounts of concentrated cannabis than adult use. Adult use consumers can only buy 1 ounce, 1,000 milligrams. But medical patients can buy more than that.
But I mean, like a package, like usually it's only 1,000. I mean, 100 milligrams per.
Yeah,
package.
No, you're right. There are products that can be manufactured with more than 1,000, and they can only be sold to patients. But so they are out there, but not many companies don't do that because they want both markets to be able to buy from them. And a lot of times people that are patients just don't get their recommendation renewed. So they're buying as adult use, but they're still using it medically. So that would like exclude them from being able to buy that 2,000 milligram product. But yeah, that's a really good question and a good observation. So do you have any like tips for somebody that's looking to add cannabis into their regimen, or any other tips like otherwise like about epilepsy that you want to share with the audience?
The main saying is start low and go slow. If you're going to start with the non-psychoactive products, the CBDs, and even CBN, which is more as for sleeping and stuff, CBG. There's even new, now we got Delta 8 and Delta 10 that are quasi legal right now, that are if you have a very low tolerance, these are good. They don't get you, if you have a high tolerance, it's not as good. I have people who've tried them and said I didn't feel anything on it. But for somebody who's starting out, it might be a product that, again, it works for you, and it's readily, or it's starting to become more available. It doesn't have to, you don't have to go to a dispensary. Some places you can order it online, I think. But protect yourself.
Get a recommendation. Speak to a cannabis doctor. If you're lucky enough to live in the LA area, California area, try to see if you can consult with Dr. Goldstein. Would be a good tip. Also, as you're like working on finding that lowest effective dose, keep records, keep a journal. Would be like another tip.
Did I mention that epilepsy is the 4th most common neurological disorder in the world, and over 65 million people in the world have epilepsy, and 3.4 million in the USA. So this isn't a minor
that's a lot
condition.
Yeah, no, that's a lot of people. And as people have probably seen on, Dr. Sanjay Gupta's special and such, there's some people that have hundreds of seizures a day. A lot of these people are very affected, where like if you have seizures all day, you're not able to go to school, you're in pain, your body is tired. So, cannabis provides a lot of hope to those people.
And a lot of help for some people.
Mm-hmm. Definitely.
Dr. Bearman shouted me out. I just got to say, Dr. Bearman has been a pioneer.
Yeah.
I mean, from the beginning, he's been persecuted for, so brave. I mean, most doctors, when most people our doctors are afraid to put their life on the line, their livelihoods. And I just can't say how much respect I have for him and how much how much knowledge he has. His father was, even researched it. Didn't your father research cannabis?
My father was a pharmacist, and one of his assignments when he was in the University of Minnesota School of Pharmacy in 1928 was to make tincture of cannabis. And I wouldn't call it research, but he said, and we had to be very careful because the alcohol was illegal. And as I said, American physicians wrote 3 million prescriptions a year in the 1920s, which is when my father started being a pharmacist. And there were over 25 over-the-counter medications that contained cannabis. And just as an aside for those of you that are history buffs, it's the oil industry who pushed the Marijuana Tax Act. And the point person was DuPont. Now, this is all sort of circumstantial evidence, if you will, but they didn't care about marijuana. They cared about hemp. And what they were concerned about hemp is DuPont was concerned because Ford always thought that automobiles should run on diesel, preferably hemp diesel. And they had a concept car that they had in the late 30s. You can Google it and get an image of Mr. Ford with the hemp mobile, if you will. Its exterior was an acrylic embedded with hemp. The upholstery was made out of hemp, and it ran on hemp diesel. So why did DuPont give any care about this? Well, number one, they were the biggest shareholder in General Motors, the competition for Ford. Number two, they made tetraethyl lead, poisonous, but no longer used, but it was an additive to gasoline. But they also made things out of cellulose. Well, with hemp, the core, the hemp herd is cellulose. And DuPont made nylon, rayon, cellophane, all made from cellulose. They developed sulfites to make paper out of wood pulp, and also could be used for making paper out of hemp. You know that the last draft of the Declaration of Independence is written on hemp paper, but it takes 4 times as much of the sulfites to make paper out of wood as it does to make paper out of hemp. And so the Congress didn't care what the American Medical Association had to say. I mean, they cared a lot more about what DuPont and what the oil companies were concerned about. And it's really a shame. Just think about all the money we've wasted locking people up, chasing people down, and
suffering. The suffering
with non-plant-based medicine.
Yep.
Opioid epidemic.
That's very true. Well, let's get to some questions. We're at the end of the webinar here. So I have a question saying, do you know if any of the varin cannabinoids can help people with epilepsy? So like CBDV, CBGV, have either of you read any research on that?
THCA is
so the acidic, one of the acidic cannabinoids,
and it doesn't get you high. It doesn't, so it's not, it has not been, it's called decarboxylated. So if you can take CBDA, and you might not feel as many of the psychoactive effects. So it's like, but it's still the same as THC, but it's undecarboxylated.
Yeah.
And it might be harder to acquire too, though.
Yeah. I think that there's still not a lot of research out there on the varying cannabinoids. You know, THCV is like one of the ones that's just starting to kind of creep into the scene. But I don't have very much information on that. So I'll have to definitely look into some research on that. Do you have anything to add to that, Dr. Bearman?
No, I agree with you that we're just really in the last 4 or 5 years, I think, gotten into looking at things other than THC and CBD. It's not that these other constituents of the plant don't have therapeutic value. They do. And when I was in practice, I had a handout that I gave to my patients that showed what the therapeutic effects of several different cannabinoids were and of what several different terpenes were. So it's not that we don't know, that we don't have an inkling as to what these things do, but we are much more knowledgeable about how they affect dogs and how they affect human beings because of it being Schedule 1. You know, every day that we go along here, we learn more and more. I think that the people that are doing research in Israel are really on top of things. But there are other researchers that are also very knowledgeable in Italy and in England. GW Pharmaceuticals is a company that makes a whole plant alcohol extract called Sativex, and they use that in treating multiple sclerosis. But they are, doing a lot of other research, and they have a lot of scientists that are pretty savvy about the plant. One of the conferences that's good to go to is the International Cannabinoid Research Society. Unfortunately, the conferences have been virtual for the last 3 years, and they rotate back and forth between North America and Europe. And I don't even know where the next one is going to be. They're usually the end of June or the beginning of July, and we're probably still going to have virtual conferences even this year.
Okay. All right. Another question. Somebody saying that their partner is subject to intractable seizures. During the last episode, this person gave their partner a few hundred milligrams of an 18-to-1 CBD to THC, so a CBD strong ratio, and it didn't work. So what would be your suggestion next? Do you think that she should?
I would try 100 milligrams of a 50-50, or I would go to maybe even less, 100 grams or less of a 50-50, and then even go to 25 grams of a full THC, or try more THC.
Let me bring one other thing in here. You heard Bill say earlier, he gets up, or at least he did get up and had cannabis every day. And I think the idea that cannabis will stop a seizure, it may stop your migraine,
Right.
but it's much more difficult to stop the seizure. But to prevent the seizures, using this on a daily basis is a good idea. And Bill's absolutely correct about the ratios, that the CBD alone is only going to work for some people, and it's only going to decrease the frequency by 30%, whereas the THC, I grant you, we're only talking about 9 people, but it did decrease the frequency in 5 or 7 people, in 5 of the 7 people by over 90%. Yeah. So people are often afraid of THC, and they're afraid of the euphoria or afraid of the dysphoria. And there's lots of things that you can do for that. I mean, the sort of streetwise person who gets too high will bite down on a peppercorn, and that has caryophyllene in it, and that will help decrease the high. Won't do much about your epilepsy, but if you're worried about getting but it may. I mean, because the caryophyllene is like CBD in terms of decreasing your anxiety, but I wouldn't recommend it for epilepsy. I'd recommend it for people that are concerned about getting too high from THC.
Very good. This is a good question. We didn't really go over this. but it's like a basic question. So somebody wants to know, is there a difference in how cannabis affects you based on how it's administered? I.e. like smoking versus eating versus taking a sublingual. And he's saying because he notices that the high feels different. So if he wanted to know.
Absolutely. When you eat cannabis, it's broken down into different chemicals, and it affects you different. When you smoke, it's a quick onset and pretty quick deceleration. When you eat cannabis, it's slow onset, comes on slow, but then it lasts a longer time. And what the problem is people eat it and they don't feel anything for half an hour, and then they take some more, and then they get the effects of the first one and the second one, and cannabis is very dose dependent. If it can have the exact opposite effect of what it can ease anxiety, or it can cause tremendous anxiety. It can cause at high dosages dizziness, disorientation, even psychotic, semi-psychotic behavior. I've had cases where people have
one of the chemicals that it is metabolized in is called 11-hydroxy THC, and 11-hydroxy THC causes more euphoria than THC, it's going to affect you. You're going to notice it maybe in 45 minutes to 75 minutes. There was a reporter, columnist for the New York Times, Maureen Dowd, who was sent out to Denver in 2014 or 2015 when it first became recreationally legal there. And so she had a candy bar. And of course, she hadn't done any research. And the candy bar had 100 milligrams of THC and less than 1 milligram of CBD. And CBD partially blocks the euphoria of THC. And the candy bar was scored in like 10 milligram dosages. And so she broke one off and ate it, waited for 15 minutes instead of 75 minutes. Nothing happened. She broke off another piece. Nothing happened. So she ate the whole damn candy bar. And she was in a fetal position for 6 hours. So, I mean, that is if you want to read what she had to say, what a naive user who took too much, it dramatically portrays exactly what Bill Britt was just talking about.
One of the benefits or curses of cannabis is that, like the person mentioned, there are so many different ways you can ingest it. There are so many different types. But that to me, that means that if this doesn't work, because everybody is so different. Everybody is so completely different. And doctors expecting, here, take this aspirin pill. This is going to affect everybody the same. No, because everybody's the same. I'm going to give you this isolated chemical that supposedly helped these people, but I don't know, but now we have this whole area, these whatever doesn't work, from, again, it doesn't get you high at all to get you totally intoxicated, but from instant onset to later onset to pills to tinctures, suppositories. I mean, there are so many, it's going to be so beneficial, especially for seniors, in the future. There's so many drugs that are going to be gotten rid of, horrible prescription drugs that are going to be replaced. 50% of all prescription drugs can be replaced by cannabis, some kind of cannabis product. But for you, your job is to find what works for you. And you have a lot of variety. There's a lot of different ways, but start low and go slow.
And another thing that might answer that too is bioavailability. So all the products have different levels of bioavailability. So like 5 milligrams smoking is not equal to 5 milligrams, like eating an edible is not equal to 5 milligrams like a topical. Your liver will, process that and will actually reduce the amount of cannabinoids that get into your bloodstream. So that's why the different methods could also feel different, even though if you're taking like the same dose.
But then somebody could be super high. That person could have a super low tolerance. Mm-hmm. So I can eat, a 500, I can eat 1,000 milligram candy bar. This person eats 10 milligrams and freaks out. So that's,
Well, look, we're all different. And while we're different heights, different weights, nobody's endocannabinoid system is exactly the same as somebody else's. So you may have more anandamide than somebody else. So you may have more of the enzyme, FA, than somebody else, or less. and those things are going to have an effect. There's no one size fits all, and I think, these seminars that you're putting on, I applaud you for that, because it helps people have a more realistic view of how the human body works, and how cannabis works in conjunction with the human body. And I'm going to push my book once again. It's available at the pharmacy, and it's also available for me, David Bearman, at cox.net. But these kinds of educational things, where you come to them with a desire to learn more, are one of the most important things that you can do in terms of figuring out, or how you figure out what is the best route of administration, as well as what is the best constituents in the plant.
That was excellent. I would have ended there, but there was one other question that I want to address, but that was a very great conclusion to everything that we've been talking about. And thanks for the kind words about the lecture series. I don't think so, but just like one last short question. Have you guys heard of any terpenes or any cannabinoids that should be avoided? I haven't heard of anything particular, but this was a question.
Well, it depends on what you want. Again, if you are uplifting, if you want uplifting, avoid the myrcene. If you want to go to sleep, avoid the limonene, linalool, or pinene. There's certain, and there, you can go online and see there's like a wheel of terpenes that show all the different terpenes and the different effects. If you Google,
Yeah.
So there is good information out there too on terpenes,
Okay.
and cannabinoid and minor cannabinoids too. But
Okay. And then we had one last question that just came in, and somebody's saying that they have seizures, that they smoke every day and they've been seizures free, but they're also on 500 milligrams of Keppra. How can they get rid of the Keppra? What would be your suggestion, Dr. Bearman, if they wanted to get off a medication? Would it be to contact their doctor or find a cannabis doctor?
Well, I think that the best person to contact would be Dr. Goldstein. When you taper off of different medications, they require different things. I mean, let's take a look not at epilepsy, but at the benzodiazepines.
I was just going to say that.
If you stop taking a benzodiazepine abruptly, you may have withdrawal symptoms for months. And I have 50 years experience in drug abuse treatment and prevention. And getting off of opiates is much easier than getting off of benzodiazepines. And most people don't realize that. So I wouldn't even venture, because I'm not a neurologist, as to what you have to do to get off Keppra. I would certainly talk to my neurologist, but if you can get an appointment with Bonnie Goldstein, this is an ad for her. I mean, I think that she would be the one that would be most likely to have the answer to that. And just some doctor that is recommending your cannabis that you're paying $39 for over the internet, the likelihood of them having even a clue is pretty low. And even your neurologist, they're certainly going to know how to get off of Keppra, but they're not really going to appreciate exactly how much cannabis does. Although I will say that a lot of neurologists have wised up in the last 10 years.
Yeah, that's a good point. And you're right. Yeah. I worked back in the good old days when doctors, really provided full service. And nowadays, with a lot of doctors just seeing their patients online, it's just more important to go see someone that's knowledgeable is the key. Right. So very good. Well, thank you so much, Dr. Bearman. Thank you so much, Bill Britt, for being here with us today. Thank you to the audience for being and watching the Pharmacy Cannabis Lecture Series. And thank you, Amy, too, Dr. Bearman's assistant, for helping to get everything arranged. I appreciate you all and all the information that you shared, the time you took to put together your presentations. I hope that we'll see you guys again back here soon on the series.
I enjoy this. I enjoy giving these talks. And, You know, the other thing is I enjoy educating physicians. And in June, I think the Ohio Medical Cannabis Doctors Association is going to have their third symposium, and I'm going to make some presentations there. One of the things that's important in terms of your audience to know is to tell your doctor the benefits that you get from cannabis. This is how we have gotten more physicians to recognize that cannabis is medicine, but also that maybe this is something that they should learn more about.
Yep. Excellent. Excellent words and excellent way to end this webinar. Thank you so much. I hope that we were able to share some information that will help everybody become better informed cannabis consumers, and that the information that we shared will help you find relief. With that, everybody have a great day. Stay well and stay high. Yep. Buy Dr.
Buy
Bearman's
Dr. Bearman's
book.
book.